Conversation to the entire school board. A couple school board members still on the way here, so I apologize for that. But the truth is, you have the two most important school board members here, so you're in good hands. Did I say that right?
Yeah, you did.
He scripted that part for me. So, but we'll go ahead and get started. And Superintendent, I'll turn it to you to get us kicked off.
Well, thank you, Mr. Weishauser and Mr. Booth. And again, we want to thank all of our partners for being here today to talk further about where we are with our health insurance coverage trust and the health clinic, and where we are moving on from here to continue to work at providing excellent care for our employees while also being a better steward of those very short trust fund dollars that we have been spending in excess over the last couple of years. So I believe, Mr. Hensley, we're going to start with our Cigna partners.
We will, yeah.
Okay.
It's been a very busy last 2 months since we last were here. A lot of activity, a lot of things are happening, a lot of pieces put together. As you all know, we opened the health center back up last week, had over 350, probably closer to 400 people come through the health center last week and saw the new furniture and saw the new providers and just a different atmosphere, and we're excited about that. So we're excited to have Cigna come to the table first today to give you kind of an abbreviated CAP report along with some initiatives that we've been engaged in for the last year and some of the positive outcomes. So with that, I'll turn it over to Dean Maribel, the market president for Cigna. I'm not sure who's running the office because I think all of Cigna is here with us today.
I did promise there were people back at the office answering the phone.
I don't think any claims are being paid right now. No questions are being answered.
Thank you for having us.
It's our pleasure.
So I'll let Dean introduce his team.
If we need to pull up more chairs, we kind of tried to squeeze around to see who needed to be where.
Just grab one of those and drag it up here if you need to.
Dr. Howell, come on up.
So I'll go ahead and kick us off. And first, again, my name is Dean Maribel. I'm the market president for Cigna. I've been with the organization for 24 years. I'm responsible for what we call our North Florida market, so I handle everything from kind of Tampa up through Jacksonville and have oversight of just the entire operation for the market. And excited to be here. And I'll let my team introduce themselves. We'll just go around the table real quick, if that's all right.
Rhea Calabrese. I'm with Cigna. I've been there 34 years. I'm responsible for some of the medical insights that we're going to review today. Thank you.
Hi, Dr. Mike Howell. I'm the medical exec for Cigna for the North Florida and the Southeast region. I work with this team, and I'm responsible for the network, the contracting, the clinical support, etc. for the team.
Janice Maurer, I'm the account manager for the school district of Osceola County. I've been with Cigna for 28 years.
Christine Caselli, I'm the Vice President of Sales of our retention in North Florida, report through Dean. Janice is on my team, and this is my 17th year with the organization.
Do you want to introduce the rest of your team that's here?
Sure, go ahead.
I'm Ron Parr, I'm the AVP of Network Management, so I'm responsible for Central Florida here in North Florida, Jacksonville. Work with Advent Health, Orlando Health, different providers here.
Peter Wallace, I manage the client informatics organization for Florida and a number of others markets across the country. Maria works on my team, so I'm eager to hear what she's saying to you guys.
Hi, Kelly Monzillo. I'm the pharmacy clinical account manager for North Florida. Been with Cigna for about 8 years. And the government education manager for Florida.
Annabelle Bladder, engagement consultant for Cigna. Brittany Dixon, Cigna on-site well-being coordinator for the school district of Osceola County.
I'm Lily, the Cigna on-site representative for the school district of Osceola.
So you were right. The whole team is here.
I was going to say, nobody's paying anything right now.
You're very important.
Yes.
Yeah. Thank you. Good answer.
So again, thank you very much for the opportunity to be here and for being a client and putting your trust in us for so many years. And we want to be very respectful of time. So we have really tried to compress this discussion today into a short time frame to make sure we can highlight some of the key areas of how the plan is actually performing and how in collaboration with everyone that's in this room we can continue to bring different recommendations and ideas. And congratulations again on it, opening up the Employee Health Center. I know that was exciting last week, and we're excited to be a part of that as well. So we look forward to those discussions and collaboration going forward. So today our goal, and this is your meeting, so anything that you want to change or direct us along the way, please. I know you won't be shy. We really want this to be an interactive conversation. Ask the questions that are on your mind, but hopefully this will provide you some basis or foundation for how the plan's been performing and some of the programs that you've implemented and have had in time, I think have driven some really strong outcomes. Recognizing we still have opportunity in front of us, and those are some of the areas that we'll really touch on throughout this afternoon.
Good.
That's good. So on the agenda, as you can see right here, so the first part of the session is really Maria, who's our informatics analyst that's here with us today, that's going to spend some time talking about what has been going on with overall medical trends. So we'll look at year-over-year medical trend within the school district, and we'll also compare how your trend's been performing relative to other school districts of similar size. So we're fortunate to work with a lot of the school districts here in the Central Florida market, but we also have quite a few across the country, and so we have a good basis and benchmarking information also that we'll share with you towards the end to give you some level of guidance and understanding of how your plan is performing compared to the rest of the K through 12 school districts around the area. So similar comparison. We're also going to talk about some of your top 3 conditions that you'll see in the presentation today, which really no surprise, we see this with a lot of our employers today, which is surrounded around cancer, musculoskeletal, as well as cardiovascular, circulatory challenges. So we'll spend a little bit of time highlighting what's happening at that level. And also around chronic condition support. So about 44% of the population today is dealing with some type of chronic condition. Again, not uncommon, not just in the public sector or school boards, but we also see this in our private sector as well. A lot of different programs out there to try to get individuals more engaged in some of these programs to try to control that healthcare and improve health, if you will, in time. We also are going to spend a little bit of time on some of the network strategies, so we won't have a chance to go through all of it, but just some high-level updates in terms of our relationships here in the Central Florida market, some of the work we're doing with what we call our accountable care organizations. This is a whole new kind of financial model that we work with the large health systems like Orlando Health and Advent and others, Baycare in Tampa, for example. And we're also going to touch a little bit on our Cigna Care designated network as well, which you're currently utilizing today, about 30% of the population. But we think there's some opportunity as well going forward, maybe in the future, to look at how we can continue to steer more of the school district employees' independence into this kind of high-performance network. From an engagement perspective, I want to take an opportunity to really commend the school district on all the work you've done over the last couple of years, because it is working. So I know some of the trends have been up, but when you take a step back and look at the savings, which we will show and illustrate throughout the conversation today, some of that great work is having an impact on the district, both from a cost perspective, but also from a quality and healthcare perspective as well. So I was looking at some of your stats, for example, on you've implemented the OMADA program, which is a pre-diabetes program. It's a weight loss program. You've had really good participation in that program so far, so that's pretty exciting. And in terms of the wellness incentives that you have been offering, which I think is a great benefit to the district employees and their dependents, almost 58% of the population is now utilizing some type of wellness incentive, which we know is a big driver of overall engagement into your healthcare dollars. A significant completion on health assessments, which we love. When we get that information, allows us to kind of work behind the scenes to really engage the customers and members, provide them the support that they need. Preventative screenings are up as well over last year by as much as 3 to 4%, and your cancer screenings are also up. So think about cervical, colon, and breast cancer screenings, all actually above the norm. Two of them are above the norm. One, we still have some opportunity. I think it's colon cancer, but still the cancer screenings are actually doing better than we see across our book of business. So again, engagement's there, and we're going to touch on a little bit of those components today, but also some recommendations for the future as well. So that's kind of high level, and then we'll provide those a couple of updates on One Guide, which is our new service model. Is there anything that we're missing, at least as part of this agenda, that you really want to make sure that we cover today, or is this a good start?
I'm good.
Good? Okay, great.
And I'll go home because he just summarized the whole thing.
So from there, we'll jump over to Maria, and we'll spend the next couple of minutes just kind of giving that high level on the actual the trend component I just mentioned, the overall medical trend.
Thank you, Dee.
Yeah.
Thank you. I forgot who's controlling here the slides. So as we look at page 4, a lot of this information I know you have gotten over the last few weeks. As Dean mentioned, some of the trend we've seen for your group overall, it's coming in below 4%, about 3.6. When I take a look at that and compare it nationally to what we're seeing on Cigna's entire book, It's coming in much more favorable than a lot of what we've seen for some of the other industries. Overall, Cigna has been managing their total book at less than 5% compared to some of our competitors. And what we're going to see here is the utilization management programs and the participation there and where your members are seeking care is really helping to control these costs. When we take a look at a 5-year glance, you're coming in at about 4.92 compared to the schools at 3. And what I did there was I know we have some unique illnesses, within our population. And when we take a couple of those sort of out of the mix, because we know they're a little different than what we see in the norm, that's worth about 2 percentage points. So then that brings us down right in line with what we're seeing with the industry, both on the school system side as well as nationally. So in a moment, let's take a look at, some of the...
So hold on, if we cut out, 10 individuals, is that what you're saying?
Actually, well, we've got the uniqueness of some of those illnesses, but then what I also did was I took a look at the members that are going between 50 to 100,000, that range. And right now, where the school district is compared to some of the other members, that right there, some of that spend, if we leveled that off a little bit, then your trend is coming right in line. So you're seeing a little bit of a higher cost between that 50 to 100 compared to what we normally see out there.
I mean, we're seeing $1,000 difference for school norms, but for us, it's what, 1,600?
When we get to page...
And that's a huge difference above the norm.
Yeah, we've got a chart where we're tracking, each of the bands of these higher claimants in a few more slides, and let's take a look at that, and then we can see where.
We'll answer those questions.
Okay.
We break it out and we show you what the claims are over
in
100,
relationship.
over 200.
I mean, because to be honest, make it sound really good, this is really bad. I mean, this is bad.
You've got
7,500 is bad,
Yeah.
especially when everybody else is 6,800, or the average is 6,800. And 5 years ago, we were the average,
Right.
and now 5 years later, we are well above the average.
There are a few claims that are driving that over.
And I know we've talked about that in the
We've
past. I
talked
mean,
about
without you guys, I know we've talked about that here.
Yeah. And this
But I
is-
mean, I know we can
Yeah.
delve into it and do all this, but in the end, this bad.
Well, and the challenge for us is that while this cost differential, this trend differential from 7,400 to
That's the last time I'll
68
see it.
compared in 2013,
Right.
we were slightly less
Right.
than the school norm, and even in 2014 and
You were.
15, we were
Yeah.
pretty close.
Exactly.
The last 3 years of differential is not sustainable,
Correct.
number one.
Right.
And number two, just like we are obligated to serve all students, we are obligated to provide health care for all of our employees. We can't take one or two and say, you have a bad disease, so you're out.
Yeah.
Right.
So we've got to figure out how we begin to mitigate these things, because this is just not sustainable. And I think that's
Correct.
maybe.
That's the
what
point
you're
I was
trying to
getting
make.
at.
Yeah.
Certainly, and I won't say what I said 5 times, but I just wanted to make that point very clear. I mean, as we go through all this, in the end, come back to this number, which is almost $7,500. And so, again, bad, not sustainable, all those things you want to say. That's a problem we've got to solve.
And that's where that early detection and engagement is going to come into play, and we can see that as we start to work through.
And not
some of
to
the
interrupt you
information.
again, that's what I heard 3 years ago from what we were going to do 3 years ago when we opened our health clinic. We were going to find all these things, we were going to fix all these things, and we were going to bring the spend down, and all we see is a trend line up. So just throw that out there as well.
So just so we're all clear, you think this is bad?
Thank you. All
Set
right.
the tone, I guess.
All right. So in taking a look at the trend overall on the account, if we take a look at some of the drivers, both on the medical side as well as the pharmacy side, we'll see some of these cost drivers. We'll dive in a little bit deeper, and then peel back some of the utilization management savings that is filtering through this, albeit not where we may want to be from a per capita standpoint, but we can see where some of the savings has been flowing through on the account. When we take a look at your total medical, we talked about some of the conditions. When we look at the cancer here identified as neoplasms, we've had our unusual share. In those top 25, 10 of those individuals unfortunately have some of that. As a result, some of the costs associated both on the medical and pharmacy side will come in hand. And then circulatory on the heart and some of the admissions we saw for the cardiac side. And so when I think of programs, I think of engagement. Those are two that, we have a focus, and we want to try to continue having a focus on those illnesses and finding different ways to do that outreach and connecting with those providers. And when we look here, whether we're looking at catastrophic or non, as you mentioned earlier, the trend is 3.6. When we take a look at pharmacy, what we see here is the non-specialties trending down at 14%, and that's a direct result of some of the plan changes you made in July of 2018, where you introduced 90 Now, you introduced a lot of the utilization management saving programs through the Essential Package Program, your step therapy, your prior authorization, some of those details came through, and we had some savings there. We're going to go over that in a moment. It looks like specialty is running at 27.8, but what's happening there is those conditions that were managed through the medical, there was a change in how both the condition and the dollars were being allocated, and they moved over to pharmacy allocation. So right now, an individual, let's say, was getting some cancer treatments, and they were having a provider administer that, so it's going to be under the medical. That specialty condition changed so that the individual could do like an oral pill for cancer. So then that moved over to get paid through the pharmacy. So when we look a little bit later and we look at specialty, medical and pharmacy combined was actually a negative 3% trend. So your specialty isn't going up. It was just a shift between the medical and the pharmacy, and we're going to look at that too overall. All right? And then just a couple of points before we move on off of this slide. As far as pharmacy, the generic usage for your group is very good. And for every point there we see in movement, we're seeing some dollar savings. So you had gone from 88.9 to 90. So that was worth a few $100,000 right there in savings. So to the extent the generic dispensing or substitution, we continue that, that's where we're realizing some of those savings as well. All right? So if we can, let's take a look at the next page, which is sort of a blueprint for the overall health of the population. We've got here the chronic members Dean mentioned a little bit earlier. We've got about 44% of our population driving about 80% of those costs. And so that's the group we're going to need to look to continue to target. And with some of the conditions we had identified a little bit earlier. Hi.
Sorry.
Sure. Page 6. So as we were talking about on page 6, we've captured some of the information on our chronic individuals.
Okay.
When we take a look at some of the health engagement, today, where we have captured the information was around 30%. Where we're moving toward and what Annabelle has pulled in for some of our metrics for the current policy year, our current plan year for 11 months is actually closer to 44% engagement. So we are seeing the direct impact of the programs we put in place for the incentive, and that's going to be our key in trying to capture some of those illnesses early on. All right, to the extent we can capture that engagement. And what we see underneath engagement is, some details behind that, how many have gone to office visits or completed a preventive exam, as well as some of our compliance with the cancer screenings that Dean was mentioning a little earlier. To the extent we continue this momentum, this is our best line of sight. If we can't catch a breast cancer diagnosis early on, you're looking at saving 2 to 3 times the cost of catching it at a stage 3 or 4, and that's just one example there. When we take a look at overall savings. We were mentioning this earlier. The utilization management, both on medical and pharmacy, as well as those Signacare designated doctors through our network that Dean mentioned, the 30% of episodes through those doctors, all that aggregates to about $4 million, where I can appreciate the 3.6 and the overall costs, where they're coming in. 4 million are real dollars that have come through, and some of them are deflection dollar savings, but they're coming through in all the programs that were worked on. All right, and we can see here, you had inpatient utilization management program. You moved to a little bit of a dial-up called Personal Health Solutions Plus. You're managing inpatient, outpatient, in addition to those case management. So we're realizing those savings, close to 1.4 million. And then you're going to now introduce in October Health Matters Care Management, and that's where we hope to get that closer lens on the health risk of those individuals. That's already incorporated in your program, and that is taking inpatient a little bit further in. It's taking a social worker, putting them in place to work with individuals. It's looking at your pre-admission, your post-admission outreach to ensure that those members have the right transitional of care so that you're not seeing those readmissions, and hopefully managing some of those higher incidences of care need there. All right.
So those are additional touches that are being added 10-1 for additional cost savings for you.
Yeah, thank you. So that's what we've realized today is 1.4 on the medical side. We're going to probably realize a little bit more once that program comes in place. The pharmacy, with all those edits we talked about in July, it was 1.2 million in savings. And then the care networks we just talked about 1.4. So members today, their episodes are being aligned with the high-performing doctors that are achieving those savings and realizing that 1.4 million in savings.
Okay, talk to me about the time frame that that this represents.
So when we captured this information, we had May through April paid through 3 months, so paid through August when we captured this. So some of these programs now are going to be effective in October, so we're going to start to see that in the new plan year. And then when you had your personal health solutions, when you did the buy-up, I believe that was on a plan year 10-1-18, so some of that's reflected here. But the more enhanced program is coming in 10-1-19, so that we're going to start seeing those results starting next year.
Okay, is this $4 million over the course of the last 12 months or over the
Yes.
course of the last 3 months?
Last 12 months.
Okay,
Yes.
so if we hadn't done these things, our plan spend would have been $4 million more
Correct.
in 2000.
That's correct.
Correct.
Okay.
And one of the major big changes that you did, you only had a year ago for 10-1, you had only inpatient pre-certification.
Right.
And then you added the outpatient pre-certification, which is all the services anywhere at an outpatient setting, an MRI, and that was a quiet transition, and that added to that savings.
And what have we done to encourage people to use this Signacare network? Or is that just happenstance that 30% of our people are using it?
Yes.
Yeah.
Yes.
So that's in your recommendations?
Right.
Okay.
Right.
Yeah. So
Right.
so we see the best, the highest utilization clearly when you start to create the benefit programs built around the Signacare network. And so we have some options that we'll show you there that we know will enhance those savings. But right now, Dr. Pace, you're correct. It just happens to be that they're part of the network and members are utilizing those physicians, and we're benefiting from the savings and higher quality as well.
And they come up first on the website. They come up first with the C there. And Dawn is well aware when someone comes and asks where they should go, they're always referred to not referred, but recommended to go to the Signacare network provider.
Go ahead.
If we're not getting itemized bills, how do we know we're saving money? That's what I'm trying to understand. If we're paying flat fees to them, and then some we're not looking at the itemized bills on the big ones, how do we know we're saving money? I'm trying to figure that
Divided
out.
by 10,000.
How are you calculating the savings off what?
So we take a look at the condition as it comes through,
Right.
and based on the algorithms behind the scenes, they'll say if this individual had gone to a provider outside, their cost would be $7,000, but they were managed at a $2,000 cost. And so the savings achieved is what gets filtered through.
What is that, I guess, what is that 2,000 number you pull out based on? If
That's-
we don't see what they're doing itemized, why, how do we know if that's a proper 2,000 or not? I mean, understand why I'm asking. I understand how you build, but
Yeah.
going forward next year, if you tell me we're spending millions and we're not seeing the itemized work being done, then we're really not watching the dollars. I mean,
Yeah.
and so when you say we're saving money, I'm trying to figure out what is that calculated against? Simply what? I mean, I can't figure it out in my brain.
I believe it would be calculated against the average spend for that geographic area. So we're going to take in those cost metrics that we know.
So the average
Yeah.
spend in this area would be
For procedure, for a
for
specific procedure.
would be basically triggered high by the hospitals. I mean, every one of us in this room have gone to our doctors and had procedures done half or more
Right.
than what the hospital wanted to pay.
Right.
So if we're figuring that in based upon the average, we're really not negotiating anything. We're just saying this is the average of what the area is, so we'll pay it. And I don't know how you then ever get to savings because you're artificially letting the provider, the big providers, generate what that average is.
The benchmarking is skewed, right?
I follow what you're saying. We'd have to take a look and think about it from a network standpoint.
So my question is, going forward, can you negotiate with the providers for rates that aren't these, well, we find that to be the average that's skewed? I mean, I'll give you a good example. If I walk into Orlando Colon Rectal and I get a colonoscopy, it's $1,500. If I go into Orlando Health, this happened to me, it's $4,000 plus. So why wouldn't I go to Orlando Health and say, if we'll give you the colonoscopies or Florida Hospital, but it's got to be $1,500, otherwise we're just going to negotiate directly to have them all done here by the same doctors. And that's where I look at you guys as our representatives. That's the negotiation to me that's going to be the only negotiations that ever save us any money, because we're always going to be talking about, well, your dollars would have went up more, and we're saving you money, which is...
So I'm kind of listening for your conversation to go far enough so I can get a better handle on it. So 2 ways I think you do that. One, you come at it from I'll call it a patient perspective. One, creating the reason for them to not go to the hospital.
Right.
And then you also do it from the provider, the doctor perspective. Make it so that the referrals that they make are not to the hospital, but to the
We all
landlord.
know that, but
Right.
at the end of the day, will your company challenge the hospitals and say, wait a second, we want to negotiate this rate because we know we can get it here like this?
The best way to challenge that, though, is to drive the business in another direction.
So steerage.
So steering. So we are steering through bundled programs, so working it out with colorectal surgeons and their facilities on an outpatient basis to pay them the higher rate versus the hospital. Now, it's not the $4,500 that you're talking about the hospital, but definitely paying more than the $1,500 that they
Why
may
would
get.
you pay more than the $1,500 if
If
that's
I-
what you get
be-
walking in? And you say,
Whether I go with the 1,500 or 1,600 or 1,400,
Right.
the whole idea is to make sure that I'm driving business to the outpatient doc and not the inpatient doc.
Right.
On the the primary care side of it, our relationship with those docs is to, if you're going to gain an incentive for doing better, you've got to actually demonstrate that you're driving it to a non-hospital facility. So we're actually working it from 2 angles. We're working at it from the angle of making sure that the specialty doctor either gets the same or a little bit more. And I'm not opposed to giving them a little bit more to drive the business their way. I need incentive. Look, the way the world operates out there, I've got to give incentives to these folks to do things differently.
Wait a second. My son's a doctor. You don't have to give an incentive to a doctor if you say, I'm going to give you the patients you want at the price you charge. So when you say, I'm okay with giving them more money, that's our money.
I'm not sure why I'm going to choose to go to a clinic as opposed to a hospital.
Yeah.
To pay more than they want to get paid. I'm very confused.
Well,
Why wouldn't I just want to pay the $1,500? I mean,
not-
I'll never know. You're driving me there.
But I'm not trying to pay more than the $1,500. My point is, we need to make it valuable for the doctor and the freestanding opportunity of instance to take the business. Look, some of these doctors are already full. Some of these doctors are at the point where they don't want additional business. We've got to create an opportunity for them to do something different. The reality of it is doctors are burning out here. And they're burning out because there's a lot of stress on them and they're quitting the practice of medicine. So I can't just say, I'm just going to drive all this business. I've got to create opportunities so they want to recruit additional providers to come work with them in those outpatient facilities, that they can do that and take on the additional business. But I've also got to make sure the primary care docs who are writing for, let me refer you to a gastroenterologist. They got to refer you to the gastroenterologist that's not automatically sending you to an Advent Health facility. So there's a lot of conversation. There's a lot of behavioral modification. You've got to do this relationship-wise. You've got to do this over time. You've got to do it consistently. But if anyone thinks you can just walk out there and snap your finger and that practice changes, I'm sorry, those practice patterns have been building and developing for dozens of years. It can be done, but you've got to line it all up correctly. We've seen it happen. We've seen physicians change the way patients are managed going to emergency rooms. We've seen emergency room rates reduced in some cases by double digits because doctors are saying, I'll stay open late, I'll refer them to a care spot and I want to be careful saying central care because I know what goes on when you may go to a central care. You sometimes get shunned into the inpatient facility. We know, but we know if you go to a freestanding urgent care, you have a better chance of getting the service you need at a multiples better cost point than you do if you go to the ER. The other piece of it that's important is that patients don't feel any of the pain. I mean, if you go to the ER, if they can't make you take,
we can drive this very quickly. You got to it. We drive this very quickly. If the patient is paying the difference in the $1,500 and the $4,500, you've just changed the behavior. You said it takes dozens of years. I think you could do it in 30 minutes.
But you've got to go at it. But you just said what I said. You've got to line all the pieces up together.
Because if I have to get a procedure,
but I also
got to pay $3,000 extra.
Is that if you can't see
the other place.
Each check mark in the checkbook, you might not be able to see how you're getting to the savings. I do understand the algorithmic approach. There is science behind this. But I will tell you, beyond the science, the practical, I'm an internist, so I'm a primary care doc. This is the kind of stuff I see. I will tell you that if I make the decision to send them over here, they will go over here. But we've got to get everybody, and then you've got to get the patient engaged. Right now, we've got a game being played by all of us that don't have a reason to do anything differently, and we've got to get it engaged.
But one thing I think is also, we don't have the solve for all of the challenges that we see in the healthcare industry today. But one thing that's helping change a lot of this is transparency. So the more data, the more information that's available, the more we can continue to drive some of these changes within the delivery system. So think about high-tech radiology, for example. I mean, so significant difference between going to a freestanding based high-tech radiology versus a hospital-based. So we've been working with our health system partners on components such as that, but also through some of the programs we have, educating customers and members on where they can get the same procedure at a much lower cost without jeopardizing quality, because the lowest price doesn't always mean the best quality, right? So we got to have the right balance of cost and quality. And so some of the things that we're doing today, Mike is very involved in this as well, is we talked a little about this in the past, is this the ACO models, the Accountable Care Organization models, which are now the foundation of building these new financial incentives to drive more accountability at the payer level as well as the provider level. So we're starting to incentivize for better outcomes. So not just cost, but better outcomes. Today, it's a fee-for-service environment, right, as a physician, right? No matter how much I run through the system, I'm going to get paid the exact same amount of rate, whatever that contract negotiated is. In the future, and I think if the health systems were sitting here, they would agree, we need to move more towards a fee-for-value model, which is not just a fixed cost, but a variable cost on the backside that rewards for quality and better outcomes, not just the rate. And so we're making really good progress, I think, in Central Florida. We're not 100% there. We're 50% there, quite honest. But I think we're doing a good job of trying to change how the healthcare delivery system works in the future.
Let me give one example of what we were talking about. When we first started working with Orlando Health and their ACO model, I think MRI CTs were running about $1,000, $1,200. We made it very, very plain to them. If you want business coming to you, you've got to make your rates come down to market. We've seen the cost on our quarterly reports that we send to them, that their cost of a CT or an MRI has come down about $500 to $600, pretty much on par with what you see in some of the freestanding facilities. Sure, you can find some freestandings where you can get it for $400, $500. But I will tell you, we said if you want the business, you've got to do something differently, because if you don't, I'm going to rally everybody in this community that's in a partnership with us to send it somewhere freestanding. Now, they kind of trumped the game a little bit when they bought Simon Med or whatever, and I think it was a Boston Diagnostic, I think it was, and kind of bought a lot of radiology facilities. There are enough independent doctors in our communities that understand that it benefits my patient more to make sure that I send them to a cost-efficient facility. That has really caught on. But I will tell you, that's what hospitals are trying to do. You have other systems that are a little more sluggish in getting to that same point. But Orlando Health really made the leap to get there, and we've seen those prices come down. So to your point, I don't have to pay more in all cases. But in some cases, we're going to have to invest to make sure the system can withstand what we're asking it to take on. Primary care docs are breaking. Their backs are breaking. And I am a little bit worried about who's going to take care of me when I get to ripe age. And I think we all need to be.
You said it's about the data, right? So does our team, do we have the data to look at and see and make those decisions?
We're working in that direction. We've got a lot of data.
I was asking you.
Me?
Yes. Do we have the data? Like you're talking about the data. You build all this data. You say that's how we make our decisions. Do we have this data in house that's generated by our employees that work for the school district of Osceola County to be able to make decisions to go back to Cigna and say, hey, this is maybe we want to drive this way, or we want to look at this? Are we able to look at that data in house that he's talking about?
Data is coming. So our system that we have signed an agreement with and Cigna are building their foundation right now. We are not computer programmers, so we hear it's on its way. We're hoping it's coming in time. So right now, our only access to data is to get reporting from Cigna at this point. So they're working with their analytics.
Deerwalk and
In the meantime,
Deerwalk and reporting are talking about transferring the data today. We've given them the sample reports and the eligibility specs for the medical, the pharmacy, and the eligibility, and we're waiting for them to accept it so we can feed it to them.
Yeah, and Deerwalk is a third-party system that is a partner to all the entities. So both the school district, Cigna, and the consultant. That's an entity that sits in the middle. That's not something that's housed within Cigna. So that's a partner for all of us to share that data. But it is a partner that Cigna works with on a lot of business and is very comfortable with sharing in that transparency.
And we'll also be feeding from the medical center into there.
Correct.
So it'll be everything, this hub of information going through there, so we can slice and dice as we want to.
Absolutely.
Right, and I think so that data, obviously, well, I know as part of the employee health centers will help drive a lot of that transparent conversations with members as they go in. But the other transparency piece is just giving the consumer, right, us as the end consumer, information on what the cost of certain services are. So we're trying to provide more and more of that transparency to Cigna customers. If you go online, mycigna.com, there are hundreds of procedures that you can actually see costs now for. So that's driving a lot of the changes and opportunity in the marketplace, and a lot of it has to be driven by benefit change. If you don't have the right benefit structure to incentivize people to go and shop, they're not going to shop, right? Think about how we shop for different products and services today. That's the way the healthcare industry is moving to provide the transparency.
And so we know we've got some work to do as we work through our plan design recommendations and negotiations over the course of the next year before we're ready for our next plan year. Because right now we've been using the soft incentives to get people to be better consumers of their health. But I think a huge step forward, even though it was a very small element, but I think it was a huge step forward to on our new insurance cards where it said activate by going to mysigna.com.
Right.
I mean, you didn't really have to activate your insurance card. You had insurance, but don't tell everybody that. But
Like a
it's
credit card.
pushing
Yeah.
people
Like a credit card.
to that mysigna.com
Yeah.
Right.
where there is a wealth of information to drive better consumerism and where all of our wellness information is located.
Right.
Your FSA stuff is all right there. So I felt like that was a very good
Yeah.
step in the right direction to push
Yes.
people in that.
So I guess
area.
part of the conversation, I guess, that we're having though is that, and please don't take this the wrong way, what I'm gonna say, is are we driving it? Are we getting the data? We're looking at it. We're making decisions that we guide and direct them to do? Or are we saying, Cigna, tell us what we need to do as part of a package, and that's what we're going to do? Or is it a big partnership where you and your team are working together? I'm going to ask him, not you guys. Do you understand where I'm going here? Are they driving the decisions that we're making? Are you driving the
Are
decisions
you
we're
talking
making?
to Ken behind me, or are you talking to me?
I'm talking to you.
If you're talking to me, I can say we're driving the train. That's
Okay.
why you guys brought me here.
Yep.
We're taking advantage of the partners and the partnerships we have that are new. And right now, we're grabbing the low-hanging fruit. 2 weeks ago, we passed international pharmacy importation. That's a huge piece. Tonight, you're going to be looking at green imaging, which is taking the actual idea that he just discussed, taking imaging out of the network and saying, if you go here, we're going to waive your copay, you're going to save money, and the plan's going to save money. Those are the pieces we can do now as we continue to develop our strategy.
Ricky, can I clarify one thing? Because this is real important for the transparency.
Yeah.
Rick, with the superintendent, are driving the teams, but everything is driven by the board. So what I've encouraged is
Yes, sir.
every decision that gets made is going to be reviewed with you at the meetings.
Correct.
So if you think it's not a good decision, or it is a good decision, so nothing's going to happen without the board now.
No, I get it. But the
Right.
point I was making was, and maybe Mr. Thacker probably knows this, is that, so if you're saying, hey, we're going to use this facility, these are the benefits, or these are the providers that are Cigna stars, or whatever the term that you use, have the C by them or whatever, did we decide that, or did they decide that? Or did we decide it together?
Kind of together. I mean, they've got their own model for doing that. We're reviewing that.
That's kind of where I was headed.
This part of the team is looking at their own ideas of what is a center of excellence. Our partners with Mitigate, they're playing a role in that, helping us find the best solutions for every element we're doing. And we're going to take the best pieces of all those, the best practices, and hopefully at the end of the day, we've created a strategic plan that's going to get us to where we want to start moving. It's not going to happen overnight. It's not going to happen in 1 year. But if we can turn the ship a little bit each year over the next 3 years, I think we'll be amazed where we'll be at if we can do the things we want to do, if we can make it happen.
When we have a meeting and we say we have data, I'm buying champagne for everybody. And I swear, it's been years. It's always going to be tomorrow when we're going to get all the data. And the next meeting is deja vu all over again. Tomorrow, we're going to be able to get the data. I mean, this isn't new. We've had this conversation since we started this whole process. I think the first time, when we first did a clinic, we couldn't get the data. We're going to get it tomorrow or next week. And I don't understand. I quite frankly don't want to come to another meeting and hear we're going to get data tomorrow.
And Mr. Thacker, I think the data is there, the vehicle and the efficiency by which we can exchange the data with the medical center and all the work that you're doing with the partners at the table. That vehicle is DeerWalk, but the data itself is there. Right now, it's just coming through ad hoc reporting, but
Which means we don't really have the data.
What
Just
you
getting a
what you
report
just
doesn't
heard
do
the
it.
chairman politely say is, it's not in any of our interests to show up at the next meeting without the data.
Yep, yes, sir.
Amen. I agree.
Absolutely.
The only other thing I would just add is just, what you're describing is something called a medical neighborhood. Just plain and simple. You decided which facilities you want in your neighborhood. You know which, so outpatient surgical facilities, you know which radiology facilities, in some cases even which doctors you want in your neighborhood, which specialists you want in your neighborhood. And once you define your neighborhood, then you decide how you want to make sure we go out and communicate that as a neighborhood. The only other thing that I would just add is when you talk about the green initiative, think about what you might be able to do to take away any barriers to going to an urgent care facility. Because what happens when I go to the ER, EMTELA will not let them take my $250 if that's your deductible, because they can't. When I go to an urgent care, to my doctor's office, even if they stay open late, there's a sign up front that says, we expect our money before you get any treatment. And people may not have that $35 to $50, whatever, and they go where they don't have to pay. So figure out how you know, as just a thought, broad thought, remove that barrier, and you can now start to drive people to other sources of care. They go to the ER because it is easy to do. They are not worried about spending the time sitting there. They're thinking about, I can get care here, and if I don't have the money, it's one-stop shopping.
Well, I was just going to share one observation. So you talked about how do we determine the Cigna Centers of Excellence. It's all of these kind of mining of those network relationships. Okay, the ecosystem of medical
The data,
care,
right?
The ecosystem of medical care, Ricky, that the school district is now putting in place with the improvements that you made to the medical center. You're, in a sense, creating your own SDOC Center of Excellence to complement that. So it is a complementary. So you're developing some approaches within that. To Dr. Howell's point, you're driving people there for free, at no out-of-pocket cost, just like we're talking about with the steerage. So in a sense, you talk about how do we do it? Well, we're paid as a national administrator of your plan, right, to help dig into and develop that and give you access to those centers of excellence. But you're doing the same thing through your own medical center here as a complement to that. So I just wanted to kind of make that correlation between the two. You create your own.
And we'll always provide you the data that we have, and we'll give you recommendations, whether you implement them or not, for us to take the data and say what could be cost savings to mitigate trend and mitigate costs. We'll give them to you always, whether you want to implement them or not. It's your choice.
We're doing our best to use the data that we have now, right? We can go through ad hoc reports and that sort of thing. But they're currently building the platform, and it will be January before it's fully operational. And when that is fully operational, we don't have to rely on the ad hoc reports anymore. And we've got, we can push a button and do some very interesting slicing and dicing and find those members that need our help, and we can attach ourselves to them very quickly.
And I would it's certainly the board's pleasure. This is your meeting, but we do want to make sure that we have opportunity for the Rosen Group and Provinsure to present their information. These are very important conversations. So if you might
I got another big
recommend-
question on the next slides.
Okay. Like I said, it's your meeting, but you let Cigna know when you're ready to move to the next group.
Okay.
You said you had a question on the next slide.
Well, number 7, and not to, I don't know where you're going, because we talked about this earlier, said, hey, we've got a ton of spend that's driving that higher number with our catastrophics, right? With our people that are, have the big illnesses that we have, spending a lot of money. But on this slide, it says that the norm is 26 and we're 27. Am I reading that wrong?
I'm sorry.
So what this is saying is it's that we're normal.
Well, if we take a look just a little bit below that on the overview, we had 84 individuals exceeding the 100,000. The norm is about 66. If we put a threshold of 50,000, which I think the board, the group here has seen over the last few months, we had 233 individuals that hit that threshold. The norm's about 174. So
that's fine, but up at the top it says total spend, average 26 of all the people you cover, right?
Right.
Our total spend is 27. I'd say that's right on the same. So
for this particular 12-month period, it would be, absolutely. And when we took a look at the 5-year is where we started seeing 2017 to 2018, where we had a little bit of our uptick.
So if the norm is 26, and the norm is 6,800 per member, and we're 27, which I would consider normal, how are we 74? Like where like is that pharmacy again? Again, I'm not.
There is
I'm
a
just,
little bit, yeah.
So, because you talked about we were going to dive into where that. It's obviously not this piece because we're normal.
Well, but I think, look, if you look at the per member per year spend for catastrophic spend.
Yeah, tell me where I'm wrong.
Page 7, the norm is $216,000. That box right down here in the middle.
Mm-hmm.
Okay? We were at 232 a year ago.
Okay.
If you remember, we have taken some steps in working with the pharmacy issue with one of our most significant
Correct.
patients to bring that down. So it has come back down to 222,000, but that's still above what the norm is per member per year.
But as everybody
I understand.
understand where
I
I'm
know.
going here, maybe I'm not catching it all right. Or am I all right?
No, some of the benchmarking is a little different. I think when they created the 5-year grid, they were doing annual views. So they're looking at plan year 2017, and this analysis here is crossing. It's May to May, so it's crossing a little.
Let me put it
but
this
I
way. Let
do
me put it this
appreciate
way.
Yep.
So the entity that you cover that has 26% of their total spend in catastrophic individuals, but spends $6,800 per member, we have 27. So why are we spending $7,500 per member? That's the question that I'd like to answer.
So I think it actually goes back to a couple of prior years, because I think you had a higher incidence of catastrophic rate in the prior years that moved you above the norm. So we're looking at.
So why we're 27 now, you're saying last year we were 35?
Right.
Yeah.
Okay.
No, last year you were probably 30 or 32%.
Okay,
Right?
okay.
This year you're lower because your catastrophic came down.
Even though
a
we
little
had
bit.
two laser
But
claims.
you have some ongoing members who are going to continue to drive very strong.
I get that.
This would
And
be
that's
all
what-
inclusive.
So a couple of years ago, you picked up some high spenders, you're gonna keep those, that's when you're above the norm. So if you go back to page 5 or 3 or 4, sorry, I don't have it in front of me.
Yeah.
You'll see where you went above the norm.
So this is for 2018, 7458 versus 6820. What is 26 and 27? Is it 2018?
It's the period that Maria talked about before, which is the May to April, I would assume.
So it's a little bit different
It's
than
like a little
this.
different.
So
than
not
that.
a full year yet.
Got it.
Rolling 12. So that's what you're gonna- and then if you also couple, the page before where you saw your chronic members being much higher than your comparators, that's going to drive a lot of additional spend as well. So you've got it at the high end, and then you've got it at that middle level, where I got a chronic member with diabetes. If they're not getting the right treatments, they're always going to be more expensive. So they're going to continue to do that. You're much higher than your peer group in number of diabetic members, which is one of the highest cost chronic members.
So what I think I may have heard you say is that that difference between the 7,800 and the 60 whatever hundred isn't necessarily from our catastrophic claims, as Mr. Booth is pointing out. It's from our percentage of people with a high spend chronic condition.
I would say it's actually both.
Right,
So
but
I
still
have a
both,
couple
yeah.
of members that were going to continue to be high-cost members that you added a few years ago that bumped you up. And I have a higher percentage of chronic members with serious conditions that drive me above the norm as well. So that's where you're seeing that differential. And again, it's part of it, but that's where when you hear us talk about we want to manage those members, if you manage those chronic members throughout time, you're going to end up with a lower net cost. If you don't manage them, that curve's going to continue to go higher, and they're going to be
We can get the statistics to line those up from the time period, so we're not looking at the crossover time period.
Yeah, no, I'm just saying, because when we started this conversation and I brought that point up, oh, well, it's catastrophic and pharmacy and all these things, well, then this number shows that that's not the difference.
You're now getting in line
Yeah.
on the more
So we're now in
recent
line,
update.
so we should be coming down to that $6,800 per member, right?
So on page 5, it says that chronic members are 80% of our costs. Are those chronic people in the catastrophic stuff, or are they separate, or they are some of both?
They are, yeah, they are part of it.
Some of them are.
Yeah, some of them are.
Okay.
That was it, thank you.
No, no problem. I know we have an interest of time. I know we have a behavioral, and then didn't know, Dean, if you wanted to touch on some of the network conversation and
Well, did you
perhaps
touch
some of
on
those issues.
pharmacy real quick?
A little bit on the pharmacy.
Did you do that?
All right, so on page 10, yeah. Yeah, I thought I'd touch on it.
Lord, we're going to go to page 10.
All right.
So how are we doing on time, Dr. Pace?
We're getting
We've got another 10 minutes.
Board members, that's up to you.
Okay.
Thinking, yeah.
Maybe just real quick on
Because
pharmacy.
this is where
I'm
we,
on the-
in the upper right-hand section of this, when we spoke a little bit earlier and we were talking about specialty pharmacy, this is where it identifies specialty pharmacy paid through pharmacy as well as paid through medical, netting to about a negative 3%. So again, that was the movement of pharmacy that was administered through the provider group versus those that come through on the pharmacy. So whenever you look at the information, if we peel it back a little bit, we can take a look and see what some of the drivers are here. So our pharmacy on the specialty showed a 27% increase, but then it was really mitigated by the decrease in medical specialty, as we said, the movement over. So it nets to the negative 3.6% overall. And that is a testament to the utilization management edits that did come in place effective July 2018. So just in encapsulating a summary here, you have over 500 members driving some of the spend in what identified here in the box at $25 million. That's medical pharmacy total episodic spend. So those
That's not for the 542 members.
The 542 members for their medical, and their pharmacy. So the total medical cost, total pharmacy cost. So the whole episode of those 542 individuals are driving
$46,000 a person.
Yeah, that's those are the higher unique illnesses.
And not to make you even worry a little bit, you notice those ads on television, the number of psoriasis ads, they've actually gone from infusion therapy to injection therapy, and they're now working on oral therapy. Every time they go to making it easier, they make a new drug and they raise the price up. So at some point when you think about your benefit, you got to ask yourself, how much control is enough control? And then if you're going to have to go through an infusion, say a drug's made through an infusion process, given through an infusion process, how do we make sure in that medical neighborhood the doctors that can infuse in their offices are the locations where you want to drive people? Because you do not want them getting infusions in hospital-based infusion centers, because that just drives your cost up. So again, this really does require aligning that benefit to get you, to keep people going where they don't need to go.
So the number I guess I'd be interested in seeing, and maybe you guys know it, so it's 4.8%. Let's say top 5%, right, of your others that fall into this norm category. So if I pulled a norm top 5%, right? So for us, it's, you add another 0.2%, let's say it's $28 million. I don't know, something like that, 26 million. Top 5%. So the norm within your group of those top 5%, what is that? Because, I mean, this number doesn't, to be honest with you, yeah, I look at that and I go, oh my gosh. But it doesn't tell me anything if every group around the top 5% is 37.6% of the spend.
From a book of business perspective, we see about 4% of the population on specialty medications driving about 28% of spend. So you're close on the percentage of utilization, just a little bit higher, but you have more expensive utilization on those specialty members. And it's some very high-cost, complex conditions.
Sure.
That are
So you,
higher than the norm.
a normal number there would be, so you think would be 30% then?
Yeah, 28 to 30% of total spend.
Well, you said 4% is
4% of
members.
the population, so 4% of members
Mhm.
take specialty drugs. And those members typically drive 28% of total healthcare spend. That's when they're hospitalized.
So get our number down to 4%. So you, instead of using 5, let's use 4. What does our top 4 spend? It's not 37%, so is it 30%? Is it 32? Is it 33?
Which 4% do you want to choose?
That bottom, the highest 4,
So-
which is the number you're using.
Right, well, I'm just trying to compare your population.
Mhm.
So I don't have the number of your 4%, but I can tell you your 4% have your highest cost. So it may actually be higher. Correct.
It probably is.
It's not a
But-
point-to-point correlation.
Okay.
We can get a report that shows that their spend by.
But again, it doesn't tell me anything until I see somebody else's 4.8% compared. You understand what I'm saying? Like, I get this is a crazy number, right? And you guys are telling me it is. But when you show me the norm is for that 4.8% somewhere else is 37, is it 32? Is it 31? Is it 26? You understand?
Yeah, no, I understand what you're saying. It's not not a 4%, so what does your 4%
Translate to.
But I think in general, you're looking at a population that is a higher utilizer and a higher.
Okay.
When we talk about these numbers, are we only, because I know at the beginning, Dean, you had mentioned we're comparing both to other school districts as well as some in the private sector as well. When we're
Sure.
making these comments about comparisons, are we primarily referencing other school districts?
Yeah, most of the norms that you're going to be referencing are going to be around the school district.
I think they
So
call
we're
it
gonna-
schools.
So there's
K-12.
about, in terms of the sample size, there's about, we have about a million covered lives today within our school systems. Correct me if I'm wrong, but right around a
1
million.
million.
So that's the norm that we're comparing against when you look at norm data. So it's a pretty big population.
Yeah, and my point would be that the patient behavior across the districts is probably on par, right? No matter where you go, the behavior is probably similar. The governance model around that and the willingness to have these conversations is vastly different.
Right.
And that's why knowing who we're comparing to is important. Because if I'm comparing to say, okay, what's the norm in how employees of school districts are consuming health care and health and wellness services, I'd say fine, that's probably all pretty similar sample. When I say compare me now to a Rosen, right, or somebody that said, you know what, we want to grab a hold of this and we want to control our costs and make sure we're making really sound business decisions to make sure that we're driving down costs, I don't want to be compared to school districts because I would submit, with all due respect to my peers, most of them probably aren't doing it right.
Yeah, no, it's a great point. I was actually gonna highlight that as well, because we know what's driving the cost, right? We can have this conversation. Now this exists. So now what do we do to manage that cost? But the big discussion here comes to what we talked about earlier. It's about awareness. It's about prevention. And where we see a higher level of engagement and active engagement is where we're seeing lower overall trends. But it comes with pretty big changes, right? In terms of what kind of changes you want to make, whether it's around benefits, whether it's around wellness, whether it's around networks. So there are things that you can do, but what change, right, sometimes causes disruption. So you got to find that right balance. But, you know, as I look at your specialty medications, and if you think about what's preventable, if you think about hypertension, if you think about certain cancers, if you think about the cardiovascular disease, a lot of these diseases that we're treating for specialty today can be prevented. But you have to be more engaged on the front end. And so that's a big effort with us internally around bringing more awareness for people to just simply get their preventative checkups, right? If you're walking around with high blood pressure, triglycerides out of range, cholesterol, BMI out of range, all of these diseases will eventually catch up to you. And that's what we're experiencing, and that's why we're trying to drive more awareness in the front end.
Are we, and I don't know who to answer this question, but you talk about BMI. Are we doing anything with like in-body scans, BMRs, anything like that to kind of look at the cellular makeup of our patients more so than just saying what's the body mass index? Because we know the BMI could be skewed all over the place, right?
Yeah.
You have an incredibly fit bodybuilder who has zero body fat. His BMI is going to be that he's obese.
I'm obese. They list me as obese. That's the way it is. I'm obese. Really. Yeah. But we're not doing those kinds of scans. I will tell you, I heard that you were using Omada.
Yeah.
It is an invasive yet non-invasive way to get people engaged in taking a closer look at their body habitus and their dietary habits.
Yeah.
So I would, we talk about your neighborhood again, that should be a cornerstone that people are driven to say, get aware, get engaged, get involved, get responsible for it.
And it's a pre-diabetes program.
It's a pre-diabetes
Right? So it's
program.
not-
470 people have participated in that program.
So no, we're not doing any of the and some of the reason because it's gadgetry. You got to make sure that stuff is proven out on a wide scale basis, large scale basis. Before
Board
you
members,
start.
again, I would just say out of respect for our other guests, I don't know where you want to drive this conversation, but we're now an hour and 12 minutes into our workshop.
Well, I'll just finish the point by saying that to me, and you guys have heard, those that have been in this room with me before have heard me say that, the key, as we all know, is it's about the lifestyle and the preventative approach to all this. And that's why I bring that up is you say BMI, people automatically think, well, I have to lose weight. Well, what type of weight? You know, what is it that you're really doing at a cellular level to transform your actual body, not just your body mass, your muscle mass, water retention, and all those other things that are happening inside of our bodies. That, I think, is the bigger piece that we've just not... I mean, we as a society, but we as a district have got to do a better job of trying to figure out how do we communicate that message to people. And it's big changes, right? Because we're humans, and the way that we behave and perform sometimes is just the path of least resistance, and it's easier to grab this as it is to choose to eat that.
Right.
But that's really where the big crux is, and that's really where, if we talk about how we're going to save money, how we're going to do all these things, you guys have a fiduciary to us to make sure that you're performing and you're providing a high-quality service that makes sure that we're working with the right doctors, the right services, finding the right savings, and have all these pieces lined up. And you guys, you have your parts. But then the other piece is, how do we all try to get ahead of this conversation as opposed to responding, reacted to it, and say, guys, as the 10,000 lives that are within our network, essentially, how do the right conversation say it's lifestyle choices? That's the key to all of this. And until we deal with that, we're going to continue to sit around boardroom tables all across the country having these conversations. The costs are only going to be moved little by little by little until we have a significant and seismic shift in the other side.
Absolutely, 100%.
I don't want to jump on top of Mr. Weisshire, but can you finish up in, like, say, 10 minutes?
Can we just go to recommendations?
Yeah,
I think we
absolutely.
should just
Take that, yeah.
Could you look
Because we have this, and I'm sure
Yeah,
Look at
so-
slide number 17 real quick. I think we mentioned this
Sure.
earlier.
Yeah.
I will.
The wellness engagement. If we could look at that, to me, this what we've done this past year is a good first step of changing the culture, and that's what you're talking about, is changing the culture where people are more engaged in taking care of themselves. So, very quickly look at 17.
So I would just I'll summarize in 7 minutes. So you have done a fantastic job offering incentives to everybody and getting more engagement. So the start was offering a significant financial incentives, your health assessment, members going online, filling out the health risk assessment. 50%, it was 30%, allowed everyone to put all their information in the Cigna system to allow them to be more engaged in the lifestyle management programs. Weight, tobacco, and stress. That's number one positive that's happened in what your employees have done. The Amada program, actually I kind of dug in a little further besides what's on the slide. 28%, 5% of the population, 28% had weight loss, and the benchmark was 29%, so they did fantastic in the pre-diabetic program. And Brittany and Annabelle and Donna have done excellent by educating and going out to the schools, not just 4 times, 5 times. I talked to Brittany, she's like, I'm out at the school, I'll call you up when I'm done. She's always out there, and she's going to promote the programs more and more. There's a tobacco cessation program. I know that the on-site medical center is going to be having a tobacco program, and we're going to work together in partnership to have them come into the Cigna program because they get the patches along with that for long-term goals. If you turn to page 20, one of the recommendations that Cigna has had year over year, and it has changed in time, is the chronic conditions. We know that we have 40% of your population are falling under the chronic. So we need to touch all the employees that have a chronic condition. We had 5. Now we have 16 conditions out there where when they fill out the health risk assessment or they call into Cigna or they talk to the member services, if you had this program, we would be able to outreach to them and either have them talk to a nurse and help them through whatever condition they have. Not everybody can, as we would like them to be, to come to the center. They are going to get some of the diabetes programs and something that they're putting together now, but the people that cannot come can get it through the Cigna programs. So we have these programs out there to have nurses, outreach, interaction, and that comes, and Maria did a population summary of who would already fall into the programs with the savings, cost savings.
And I think there's a great opportunity, I think Janice mentioned, as to how we can kind of coordinate even with the employee health centers, right? So I know a lot of that ongoing engagement is going to be done there. This would be, almost incremental to that, but I think there could be really some good, strong collaboration to bring in more support to the members that are in some of these chronic programs today, or chronic conditions today.
If we looked at the population as it is today on page 21, and you can read it later, but we projected estimated savings if the members were in the program today, approximately $22 of PMPM savings and a potential additional claim savings there in the future.
Yeah, and those savings, I'm sorry. I was just going to say those savings include, absenteeism and those productivity, getting back that productivity savings. Okay. That's
I'll
a good
just,
list.
and I know we're running out of time, so this will be the last, what I'll call an opportunity for the school district. So if you turn to slide 22, it touches on Cigna's One Guide. So I'll summarize this. The world today is about just-in-time information at the very personalized consumer level. We want that in every single thing that we do. So Cigna recognized that back in 2016 and saw where, we all are glued to our iPhones and we want it just in time when we're having that service, when we're spending that dollar, when we're having that engagement with the physician. So we started with about 100,000 members back in 2016, and we're up to 6.3 million members on this program today. So think about this as a concierge customer service model. And why it's important is when you have a member that calls into your number on your card, they're calling in with a situation. They're calling in with a question. Typically 55% is around pharmacy. They're trying to find a network provider to go to, etc. That is that opportunity where they have called you and you have an engaged customer that you can inform, direct, steer to a lot of our earlier conversation, even talk specifically about the local medical center. So all that can be customized for a client. So we did some analysis on our large book of business around One Guide and then specifically to your membership. So to implement One Guide, we think will produce a significant claim savings of over $2 million by implementing this. How do you get there? You talk to an individual that a kind of customized computer can see that whole person. So you call in for a dental claim, I can see if you missed your preventative visit. I can see a gap in care on a prescription you didn't fill. I can redirect you into a lifestyle management program because I see that you just got diagnosed with diabetes, and I want you to know that there's programs that can get you in there. So it's a real time, we're going to have that individual look at their next best action, they call it, right? So what can that individual do? And make sure they walk away with no homework. Let me engage your physician for you while you're on the telephone. Let me look up how far away that pharmacy is, et cetera, et cetera. So it's a different way to capture a member and really at a real-time basis get it into all these programs that we've talked about. If you don't do that, then we'll be sitting around this board table year over year over year. So that's one of the biggest recommendations we have, kind of to close up our conversation.
It's essentially like a concierge service? Is that another, yeah?
Yes.
Yeah, I mean, I define it like this. You got a transactional kind of customer service today, which is 24/7, which is important. Some people just want that transactional calling in. I want to check on a network, a doc, a member eligibility, and then you've got a very consultative customer service model, and that's what this is. Yeah. Still 24/7.
Across all industries, you see it. You go to buy shoes, you go to buy something on Apple, all of it has that larger algorithm behind that sees that whole person and all their buying habits. We've incorporated that kind of whole person view into a customer service model. Still 24/7, 365 days a year, still the same number on your ID card. They're just redirected into a higher touch, more effective service model through this One Guide. Okay? So we thank you for your time. There's a lot more information in here. Our entire team is open from any questions from the board or superintendent or anybody that's been listening today. So we're happy to answer any questions. But again, we thank you for your time.
Before you break, the One Guide, there's a additional cost tied to utilizing that?
Yes, there is.
Have you guys provided that to the staff yet?
Yeah, so there's a fixed cost charge, and then we show kind of that net total pharmacy and medical savings based on your own utilization patterns, and so then you see a net savings, and it's significant.
All the programs have a PEPM, a claim savings.
So we'll provide all those financials to you guys. Yeah.
And we provided one slide for benchmarking, but there is we do have believe it or not, it's about a 30-page deck on benchmarking. So if you really wanted to go deep in terms of what's happening across the entire book of business, across benefits, products, networks, we can provide that to you as well. There's a lot of information.
A lot of information.
One last comment. I just want to say personally, I won't speak for these. I don't know how anyone feels. Thank you guys for being here. Thank you for bringing out the team and really showing the level of interest you have in working with the school board in perpetuity. I know that there's been a lot of tension around the conversation. The fact that you guys came out full force to say we're here, we want to make sure that all the experts are in the room. It does mean something to me personally. So appreciate that.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Okay. They're going to be changing out the slide presentation, and while they're doing that, and
Can I
the
just get a
Rosen.
bottle of water?
Sure, of course you can. That's what they're there for, absolutely.
Yeah.
If anybody else needs
Yeah,
it.
$42.
No, I know, I'm choking myself.
We'll send that, we'll bill you for that.
But that's what they're there for. So.
Just one quick note in regards to the one guide. We are aware of the pricing for it. I kind of put that on hold because I want to see what the Deer Walk and some of the care management that they're bringing to the table and see which one works best for us to get the best bang for our buck.
Yeah, just so you know, I wasn't implying I wanted, I was just curious.
Yeah,
Yeah.
it's reasonably priced, but since we had two options, I really wanted to see the other one before we make that final decision. But we'll be bringing something to you in the next few months. Very quickly, as we're turning it over to Ashley and his team, I want to say thanks to the Rosen and Provencher team. They've worked like mad in the last month to make things work. I'd be remiss to say that we were still having challenges that we're overcoming. Everything from phone systems to obtaining the patient record. We still have not received any patient records, and therefore we're having to treat every patient as a new patient, which obviously takes more time and is filling up our schedule day in and day out. We're working very diligently. I know there was another meeting today to discuss that, to try to get that off High Center and get that into our system where we can.
By January, we'll have it.
Where is this data coming from?
From our former partners. Okay.
And our insurance provider doesn't have a lot of that since it all runs through there?
They wouldn't have the claims data. They wouldn't have the detail of what actually transpired inside the health center.
Not the details to
It's
it.
part of that same problem we worked on a month ago. So just
They feel
wanted you to
like
be
they
aware
had
of
you there,
that.
But they don't know what you were diagnosed with and what medications you were taking.
But we are progressing through it. We are seeing patients every day. We have full schedules every day and are working to stabilize the health center as quickly as we can. Kenneth and his team have just done wonderful things, and we've had some great results already. You know, the staff, the providers that are there are doing quality work and things that I hadn't seen in a long time. So,
And one of the things that we're doing also to support the momentum that we have going forward is to send out a communication to staff as a part of our newsletter. My little 90-second brief will be about getting appointments with the health center and the importance of planning ahead and what options you have if you can't get into the health center and kind of where we are, because I think that's one of the challenges that we faced in the past was we didn't stay on top of and in front of communication. And so we want to make sure that we keep the positive momentum that we have established with the reopening of the health center as we move forward. It's just, as Ricky has very kindly shared, a lot of unforeseen challenges in the changeover in terms of our health center providers that we would not have anticipated, but we are continuing to work through those, and the team has been dedicated to just doing what's right for our employees. So that's where we are.
I also want to share that Kenneth and I have kind of become connected at the hip. We're doing a road show. We've had like 3. Today we were at Osceola High School speaking to all the custodial staff.
That was fun.
Great crowd, and they were very positive and excited that we were out there visiting with them, letting them know what's happening. So
And taking flu shots directly to our custodial training today. It was awesome.
Yeah, cool. So we'll continue to do that. All yours.
Correct.
We have 35 minutes.
All right.
Well, you have probably until about 10 after 5, okay?
So we'll get the point, but thank you for the kind words, and the partnership is really starting to gel between all of us, I think, between Cigna and the school board and our teams, and to mitigate folks. So again, thanks for us being here. Kenneth is going to start off with the health center side, and then I'll follow it up with the consultant side.
So we had at our last board meeting, we talked about a couple things that we were going to, what we're going to do for the health center as we continue to open the facility. Acclimating patients to the new healthcare center mindset, and Dr. Pace, you hit it right on the head. The previous provider was encouraging those walk-ins, and we want the employees to call us, because there's going to be situations, there's going to be times that it's not appropriate to see us. If they're having chest pain or a heart attack, and we deem, you need to go to the emergency room, call 911 now. And we want to bring them in, and so they're not sitting and waiting. We want to bring them in when they can schedule at that moment. So we're moving to a same day, next day kind of mindset. And we're bringing patients in with Cigna talking about all those hypertensive patients. There was one day, that's all I was hearing. This person, hypertension, where they were telling us that they didn't know that we were going to be closed. And I said to a couple of those individuals, I know there was emails from Dr. Pace, and one of those individuals actually said to me, oh, I remember getting an email from Dr. Pace. Maybe I should read it. And she was so...
Thanks for deflating me.
Was it a board member that said that?
She was a little sweet, little Hispanic lady. She was trying to get in, and I was coming at that time. And same with another gentleman who, very, very, very large gentleman that I thought, when I walked up, he was trying to get into the facility. We had the keys maybe for 2 days. And I walked up to him and approached him, and I had somebody who was with me that could speak Spanish, and he was upset because we were closed, and I apologized, and he said he didn't have his medications and those type of things, but we guided him to the service that he needed, and he's been one of our favorite patients, and thank goodness, because he would crush me like this. Creating a culture of hospitality, we're working our tails off for this. Working our tails off for the hospitality mindset, and we are recognizing there's levels of expectations that even today, with a patient who complained that we only spent 5 minutes with that individual, but when you look at the record and talk to the provider, that provider walked that patient around the health facility after the provider saw her. So we're still trying to dive into what is the expectation? Was it truly you felt 5 minutes? Or looking at the provider's notes, wow, she did spend time. There's no way she could have accomplished that in 5 minutes. So we're still working on that piece. Establish new and returning patients to the health center. This is where we're getting challenged with, because there's a lot of patients who are coming to us that have been out of their medications, those hypertensives, out of their medications for weeks. We've got to fix that. Monitor utilization and adjust staffing models. We are doing that actively. We had a mindset of what we wanted to do, to spend significant time with each patient to get to know them. We've actually changed a little bit to reduce that so we can get the patients in quickly, because there's those patients who do need us, like those diabetics that are out of their medicines and those type. We know they're there. We're seeing them. There's one day I literally said, we are a hypertension clinic today. Strong on-site presence here. We've gone out to, like Greg said, we went to that custodial population. That was a lot of fun. Brittany and I went to... Yeah, that was a lot of fun. I think there were 65 of those individuals there. We got to talk with them. We got to get personal with them and transparent with them. That we're working on this, but they need to work with us as the champions. And some of them had some things that they wanted addressed from previous experiences, and we actually talked with them about those. And Rick, Lauren, and Brittany were there with us. And collecting patient feedback. Right now, it's all anecdotal. We're working on our systems. As we heard, we've had a lot of system challenges, but we're working on getting those in more of a systematic survey, so that we can provide you with those surveys electronically, so you can see what are areas we're doing great or what are areas that we have to improve on. So we're working on that piece. This is a little bit of what we've been doing. We're looking for MDs. You know, the providers, the physicians, the MDs, DOs that have come our way, not the quality that we're looking for. So we're actively trying to find those MDs. We've got, I think, an interview on Thursday. We've got another one that just came across our desk. So we're spreading the word. I reached out to Dr. German, Dr. Sharon from the Orange County Health Department. We've reached out to a lot of our partners to figure out, is there any physicians out in this area that want to work for us. We've had some interviews, but then once they took a look at the distance, they decided that wasn't a good fit for them. Some of the accomplishments. Now remember, we opened up. We had 8 days, and then like Dr. Pace had mentioned, we had a lot of challenges. Even to the day we opened, those challenges were there, where we were actually using paper. So that's where we were that day. That next day, the very next day, we were able to get our system stabilized, and we were able to fix things. We went digital faxing. We have a patient self-check-in. We were able to accomplish that. So patients don't have to come to the front desk. They can just check in electronically. EKG integration, that's going right into our system. Generic drugs, over 1,500 drugs we brought in and had to restock everything. So that was a period also during that 8 days that we had. International Pharmacy Program, that was part of our training process, because that's going to bring a significant savings for not only from the health center side, but from the plan side. Trained on musculoskeletal. We had a very positive patient seen by Leslie who walked in, literally couldn't feel, had numbness and tingling down their leg. Leslie was able to do the IMC method that she was trained on, that our provider, who's going to be our physical therapist, is also trained on. The patient walked out that day, all gone. The pain was gone. And Leslie can give you a testimony on that. Lab results integrated right into the patient's chart. That was huge for us because that's what we're accustomed to. That wasn't there before. It is something we have now. So when the labs come in, it goes right into Rick's chart, and now we can start trending it to show, okay, what has been Rick's cholesterol level. And talking about cholesterol level, we had a patient who came in, and he had a blood cholesterol level of 1900. I literally turned to our dietitian. I said, "Did you hear 1900?" The patient had been treated, but waited a significant amount of time to come back and follow up, and so we were able to take care of that patient. Electronic registration, that's wonderful to have because now you go right online and you get all that information, goes right into your patient's chart. That's something that was important to us. Flu vaccines, vaccines in general, significant increase on the vaccines, especially the Shingrix, which is for shingles. And we're giving those out like water, because then that prevents a patient who gets shingles from going to the emergency room or to an urgent care facility because it's very, very painful. These are some of the challenges, and we should put phones down here, but you know the challenges that we've had. First day, October 1st, many of the patients, they were used to that previous model, and we talked about what we're changing there. On the workers' comp side, we have been inundated from those walk-ins and just the stabilizing of those hypertensive patients and those diabetics that you guys are talking about, that we are asking for a delay on the workers' comp because that's something that we can bring on board, but let us fix the hypertension, the diabetes, that 80% that Cigna was just talking about. That's what we're going after, that piece of it. Discover that they delayed care. Some of those patients did delay care until we came on board. Some of those individuals are actually new that they are giving us a try, which is wonderful and what we wanted to accomplish. Again, many of them, all of them during that period of time, the only little complaints were a little bit about phones. We can call you guys and those type of things, but we worked through it and we were able to stabilize it. Physical therapy, we started the base physical therapy. It's not the IMC method that we're going to be bringing in. That provider starts on November 1st or 2nd. It's at least got us to a baseline to bring back those patients who are receiving physical therapy from Advent Health. So we're bringing those back. This was just a quick snapshot from the first week. Some of the piece that we didn't include. So the piece that we didn't include was that out of those individuals, 90% of those individuals actually went to the web and actually enrolled on the patient portal. That's important so that they're getting information that when we draw that blood, it goes right into the portal. When we do the evaluation, it's going into the portal. So then that reduces the number of times people have to call us. The information is there and available to them. The second week, we actually increased our utilization by 15%, and we had almost 80% of those individuals apply for the web portal. So here's where we're going in the future. IMC therapy, this is going to be big because you saw what was your second line item. I think it was musculoskeletal. We're going to be attacking that. It's going to help us reduce our overall spend. X-ray, we're working with Rick and getting things transferred from the previous provider from a permit standpoint so we can start doing those X-rays in-house again. From a Wi-Fi standpoint, our Wi-Fi, we had no Wi-Fi, had to redo the whole entire thing. We're bringing the X-ray, we're going from a PAC system straight to a cloud-based, and the Wi-Fi system was very important for us to move in that direction. Ultrasound, we're going to be evaluating that. Still, that evaluation is going to be dependent on some of the votes that are going to be happening today for us to make a determination. It doesn't make sense to bring it in-house versus what you guys are going to be voting on tonight. Direct contracting, that's what you're working on. Rick and I are working on the DMEs, International Pharmacy. We're going to watch this number very closely because that's where you're going to see, because you look at all your brands and your specialty, that's where we're going to be attacking it. Mental health, our team, Rick, and your CFO, Terry?
Tammy.
We were able to talk because
HR director.
Literally today, if we would have had that mental health therapist, we could have probably saved Leslie about an hour and a half today. 2 patients. She said last week, 3 patients. We had a patient who was dropped off at our doorstep, bawling her eyes out. So we're encouraging you to allow us to have that mental health therapist on site.
I can see our CFO in the mental health program.
It's the HR person.
It was Tammy that we met by phone with.
And
I feel confident we can extend our EAP services. Yeah.
And you have a beautiful EAP program. It's 10 visits per year per
really
problem.
nice, yeah.
And I'm very impressed. We're going to use it.
Yes.
There's language in the
Kenneth,
contract to allow on-site. We just have never activated it. So we're working to
Get that
come
done.
up with a provider to bring it on-site.
Yep. So once we get that check mark, we're going to run with it because, again, if I'm listening to Leslie saying she could have saved an hour and a half, that's an hour and a half we could have given to other patients when we recognize and transfer them over to that mental health therapist at that moment and at that care. The patient who was dropped off the previous week, we got on the phone with EAP and were able to serve her at that moment on the phone. But it's a little bit different. But at least we stabilized her, got her the help she needed, and she was taken care of from our facility. Chiropractor, we've already met with a chiropractor. That's something that we would like to evaluate, to look at. Does it make sense? Because in your physical therapy room, you have 3 exam rooms. It's not going to impact the health center at all, bring in a chiropractor or even the podiatrist. So I've had a conversation with a podiatrist already on the phone. He's coming out to meet with us on Thursday so that we can continue to drive services into the health center and out of the health system.
As we're connecting with the physicians, would you let me run checks on them as to their litigation backgrounds?
Yes.
The last thing I want to do is find out.
That's a great idea.
We got somebody who has 25 claims.
It's a great idea.
Yeah, and usually what we'll do is we go to the state site and we
Right.
look at that. But I'll definitely, if there's an interest, and also, it's really
It's
all
easy. It
preliminary.
takes me a few minutes and I'll know immediately.
Not a problem. So this is the website, and this is going to be where patients are going to be able to schedule appointments. Now, we've had a little hiccup with it. When we tested it, it was actually double booking our providers, and that's not what we want to do. Because then that's just poor service. Here you're going to be able to see all of the team members, and we're adding some more team members that are just missing, but you're going to see those individuals. You can look at their bios. So this is our goal, to get this up and running. Hopefully it's going to be cleaned up this week, so then we can launch it for the employees. This is what it will look like, where they can select, what is it that you want to come in for a physical or a physical therapy or what have you, and then they can select the provider. And they'll put that information. One of the last pieces we're trying to make sure is that not anybody can just access this. And if they did, what's our check on the background to make sure that that individual does have the health plan? And here is where we're going to be double checking to make sure. And then here is the pre-employment drug screening. Rick and I are working on that piece. We finally got some of the things that we needed, such as materials. So we're hopefully going to get that done this week so we can start migrating. We have a meeting with HR Thursday. So I think we're trying for Thursday.
I think so, yeah.
We're trying for Thursday because we need to understand what does HR want and what do we need to do to make sure we're meeting their expectations. On-site radiology, we're working on that. It's already gone. We're going to send the application to the state. Workers' comp, we're asking for December 1st because that's, again, we've got to stabilize. I mean, our systems are still up and down, and we need to fix the things that are coming at us. Getting those individuals some of those medications and making sure that they're getting what they need when they need it.
Just if I could make a point real quick, we have moved that away from the Centricare group to CareSpot. Kenneth has a relationship with them, gave us great pricing. It's been migrated into our system with Johns Eastern, so it's going to be seamless. And I think, at least for the time being, it's probably a better use of our health center capacity for now. And then we'll migrate it over once we feel comfortable that we've got the right people and the right pieces in place.
Absolutely, and one of the important pieces is that as we migrate it back, there's going to be days that you're going to have a workers' comp on a Saturday afternoon or a Sunday. We want to make sure that we capture that individual back to the health center and have that relationship with the other provider. And that's what we've done at Rosen. So we're just taking that model and bringing it over to SDOC. We're not going to bring you problems without solutions. DOT drug screening, we're working on this piece of it, and the DOT physicals, we're working on this piece of it. Again, we want to make sure we're using our bang for the buck, and we're going to get that done.
Can I ask you to address one thing, just walk-ins?
Yes.
We all met on walk-ins, and I'd like you to go over the fact we really want to get away from that concept, and just so the board understands the approach, because it's the walk-in who doesn't get served that will call and raise an issue.
Sure. Yeah.
So
Yeah,
I
absolutely.
think it's important if you would just go over that.
Absolutely. And, some of the walk-ins that we did have, we had an individual who had shoulder pain for 3 weeks. We were able to serve her, but we want to make sure that we're moving away from that just walk in whenever you want to mindset, because we have patients that we schedule. Now, we do have spots throughout the day that we're using for those urgent care same-day appointments. But if somebody walks in at, say, 7 o'clock, and that next available spot's at 9, they could have just called us and we said, you know what, you get that spot. We're going to put you into that spot. Or because you're an established patient and we know you've had upper respiratory or urinary tract infections, we know you as a patient, we can treat you over the phone. There's things that we can do once the patients are established with us right now. We don't know these patients. And some of these patients are coming to us asking us for, certain labs that their specialists want or certain drugs that they want us to continue. There's some things that, from a primary care world, we shouldn't be doing. Like the ADH drugs and those type of things are for specialists. And maybe some of the sleep drugs are for specialists because there's drugs out there that people are walking around naked because of the drug itself. It causes some challenges. So we're being very mindful with what we can do. For the record, we've only done it one time.
I knew you were talking about him on that
It's something to do with a corn maze, didn't
We have not
it?
disclosed any patient health information. But so we're looking at what is appropriate at your health center. But one of the things that I wanted you to know was while your 400 individuals were walking through your health center for our grand opening, did you know that we had a patient in there and we had her hooked up to an IV? We avoided an urgent care and emergency room visit, and that was a walk-in. So we've started our first IV. I was really excited. She's doing very well. I actually got to talk to her even prior to, and I'm very proud of that. What the number I'd like to continue to see is watch all those IVs. I just want to continue to see those used because sometimes patients just need that type of therapy.
So we're talking about we don't want walk-ins. Is there a really good way to communicate? I mean,
We're going to try with our
maybe
video newsletter.
Don't dig it deep into a newsletter. Maybe
It's going
one
to be the first
email.
thing that pops
boom,
up.
Boom.
It's the first thing
Plan
that pops
ahead.
up. Plan ahead.
Yeah.
So, and it's a real positive, short, to the point kind of a message, and it gives people alternatives of where they can go if they need that urgent care service.
I just want to reiterate, though, that the point when the medical center was first designed to be population health, and then they stopped doing it and want to just do walk-ins. So we're kind of going back to the way it really was designed for.
Where it was intended.
Correct.
Talk to me a little bit about the staffing model and your concerns about where you stand now and what the goal is and the timeline to get there.
So the concerns are on the physician side. We've gotten some great nurse practitioners. We have another interview, I think 2 interviews on Thursday for more nurse practitioners. Just the physician. I mean, we want 2 physicians is our goal. But again, the quality of the ones that are coming to us are not on par. So we're continuing to spread that word. I reached out to our chiropractor, and he sent somebody to us. So we're trying to get somebody, I guess, in the Osceola County area. I know, Rick, you sent us somebody that you had known. So we're going through those applications. And
I heard the Rosen Group has some you could recruit.
Yeah.
There's one we really want bad.
Drive all the way out here. So yes,
What's your intended timeline?
Our intended. So
Tomorrow.
Tomorrow would be.
If you know of anybody.
So the same time the data, you're going to have the doctor tomorrow.
The data will be January. And so the physician, we're just going to keep on. We're not going to settle.
That's important. Osceola Medical Society.
I have not. Do you have a
Osceola
contact?
County Medical Society is one place you can reach out to. They probably have an administrator, and they might review some leads on new docs in this area or docs who have capacity and can come do some work with you
part-time.
as you get by you some time.
We've actually reached out to, there's a couple physicians that want to work part-time, and we can mold that into our model. We can make that work. Because, again, the physicians are going more to the work-life balance type of world where they want that part-time. Even at our Rosen, we have several physicians that are part-time. So if we get a quality physician on the part-time realm that wants to work with us, we'll definitely consider it. But again, it's going to be based off of their mindset. If they're an urgent care mindset or get them in, get them out mindset, then that's not what we want.
I want to go to that model too.
Yeah.
Part-time?
Part-time.
So I know
I'm trying to figure out that model.
Me too.
I know the goal in your concern is around quality, and we all agree on that. But give me your, like, a genuine goal. Like, I want to have the two docs in place by X. Like, what is your stated goal?
My goal would be January, if I can have 2 quality physicians.
Okay. Thank you.
We're going to continue to drive those the applications and the awareness, and thank you, Doc. I'll reach out to the Osceola, and we'll continue to work to find them.
Okay.
And that was part of the conversation I had with Brent the other day.
Finding some docs.
In his ACO network out of St. Cloud, if he has some capacity, some docs with capacity.
I think
One
we've been
day a
struggling
week,
with
2
the
days a
same
week.
thing with
Yeah.
their small
Yeah.
satellite offices. They've been
That's
struggling.
that's the only way to make
Serving
it
on
work
that
these
board,
days.
I've heard that discussion as well.
But we got to remember, nationwide, we have a physician shortage and a nursing shortage, so that we're just
We're
competing
losing
with
around
them.
15,000 bodies a year
Yeah.
in the
In the
in the
physician
NDDO
We're
world.
not trying to get a really good doctor at a market basement price to where it's not going to happen.
That was going to be my question.
No.
Competitive side.
Correct.
Are you
But a
ready?
lot of them, why they're attracted, or why a lot of our Rosen doctors are attracted, is
But do you have a part
all
of
they
this?
do is treat.
Yeah.
They don't have to deal with any more
You don't have to run a
business office stuff anymore.
I would
All they do
think
is
that
treat.
There's got to be some good local ones who would say, you know what, I'd rather go do this and leave.
And
the
leave
headache of
everything at
running
home.
my own little.
Correct.
Yeah.
It's that balance
That's why I
that he was
think
talking
that
about.
Osceola Medical Society, they may have some.
They got into the business to fix people, and then found out they got to be
Fix it
doing this
themselves.
billing and all this
Business, yeah.
stuff that drives them
Or
nuts.
they get bought out by the hospitals, and now they're looking for the hospital
Yeah,
system.
speaking of which, as we do agreements with these, like colon rectal groups, radiology groups, let's make sure we put something in there that they can't compete or something if they get bought by a hospital, because the hospital's trying to buy everybody up. What I don't want to do is have Cigna and you guys build this great relationship, and then they're in the back door saying to Advent Health, hey, guess what, we've got all this if you buy us.
Right.
And we've added value to them, and now we're back to the same step we were before.
And let's make sure we keep control of the records too, so we're not in this.
Yeah.
Speaking
Yes.
of which, are we
Yes.
getting, Carolyn, we were having issues, and Rick, with how fast we were getting the medical records from Advent Health. Has that been fixed?
That is still
Where we were at the
on-
first count right now.
Yeah, we were still in High Center. They had a meeting, a telephone conversation this morning at 11, and they're trying a different route from a data transfer method that they're going to try, and they're testing. So I asked if we needed to bring the big guns in, and they said, let's hold off a little bit.
And it's hurting the patients the
No,
most.
that's
That's
why.
what's so sad.
Your turn, Ashley?
All right, okay, I'll get us through here pretty quickly. We're going to start off just with some historical data on page 14. Carolyn, you just kind of keep up with me if you can. I think the key points here are back in the 16-17 year, you were at about 54 million. 17-18, you trended up about 12% to 61 million. And then you finally trended up another 13.3% up to almost 70 million, and that's only for 11 months. That's when the report was run, so it's well over 70 for the 12 month. I think it's important to say that even if I would have told you it was 54 million and it went to 54 million and it went to 54 million, I think that's too high of a number. Okay, so let's don't, sometimes charts and trends and the way you slice and dice stuff can kind of make you feel good, but we don't want you to feel good about stuff you shouldn't feel good about.
The other thing I want to comment here is, so right now we're at 69 million for 11 months. and then we had to factor in the medical center into that. So we're clearly over $70 million, because you have to factor in not only the medical claims and the prescription claims, but we have fixed costs. And it was a cost to run our plan. So that's all factored into that. But yeah, it's not a good picture right now.
Yeah, and I think just to kind of remind you on the medical center side, although we want it to run as efficiently as we possibly can, not waste money, we do project over time that is going to trend up. That cost is going to trend up because we're bringing in more tools. We're making it more comprehensive, and it's going to drive these numbers down is the plan.
So, for example, international pharmacy, that's being run out of the medical center. So we're going to absorb all of that cost into the medical center, but it's going to come away from the prescription drug costs.
Fine with that, anything, you should be spending money that's cheaper.
Correct. But it's going to be in a different bucket.
So the next page is your claims for the last year, for the last 11 months that are over $200,000. So you have 27 claims that are costing you on an annual basis almost $10 million. If you go to the next page, we've got 63 claims that are between $50,000 and $200,000 at almost with 12 months of data, it's probably close to $7 million. It's interesting that in 17-18 year, you had 81 members over 100,000, and now you've got, in just 11 months, you've got 84 over 100,000. So just, in general, we're taking a trend that it's going in a direction that we don't want, and we're going to reverse that. And we reverse that through fixing people. And even folks that need to have care and go to the doctor, go to the hospital, et cetera, doing that with high-quality providers at lower costs. And then finally, once we can get to the point where we can audit these bills, we'll find mistakes that will drive these numbers downward. There's one interesting, just a quick comment. There's a rattlesnake bite in here, and it costs about $58,000. And usually, you need about 5 vials of anti-venom that's in the $2,500 range. Now, listen, there's some ancillary costs on top of that, but $58,000 seems, again, once until we can audit and that sort of thing, we don't know if that could be valid. It's $58,000, but it is a red flag that says something doesn't seem quite right.
Not a lot of money if you're the one that's bid.
Yeah, but it's interesting that the Washington Post, and actually Carl did a little series on this as well, but the Washington Post did a little study on snake bites, and they just found out that hospitals were just charging outrageous prices across the country. I mean, just very egregious costs. And there was our solution for doing medical bill review, that particular vendor that we hope to use when it's finally time, found a snake bite, and it was $950,000 that had been paid, and then after the medical bill review, they knocked it down to, I think it was in the
I know 25. The guy that milks the snakes.
Yeah.
If you want me to introduce him to you, you want direct pricing, I'll set it up for you.
Yeah.
But he's right over there in St. Cloud. Yeah.
But instead of those 4 or 6 vials, they on the medical center reported,
you might can buy directly
40 to 60.
40 vials rather than 4.
40?
That's what the bill was, $950,000 versus what it should have
Ash, I've got a question.
Yeah.
Back in the Cigna report, there was, I don't remember the number, 250 some odd patients or something that were, what's that number, do you remember?
There's different reports that use a $200,000 line item, a $100,000 line item.
It was 250 something members that were, I can't find it now, so it doesn't.
It pulls the last time somebody also was at the doctor's office. I don't want to assume, but that may not be the only reason why the member went to the doctors, the venom. If there may be other diagnosis behind it that's pulling that total cost.
Okay.
Because I know sometimes it's not clear and something doesn't make sense, and that's where I go to the nurse and we'll dig into a diagnosis for you.
We could have aggregated that total cost over the last 4 months, and they just happen to be in the ER for that same time.
Okay, so.
Okay, so this is interesting. When you're looking at the, for those that have the printed copy, it kind of, this feeds from the bottom. So just, I'm going to start out kind of at the bottom of that page 17. So here are some of the initiatives that are being implemented, and we just want to kind of share with you at what stage in the process we are. Health Center obviously has been implemented. The projected potential savings somewhere in the $5 to $10 million range. Active data mining, Deer Walk, we talked about that. It's being installed now. An analyst has been hired, and this is knowledge is power, right? And this, as you all know, is where we're going to be able to find, savings. 10% of your folks are costing you 80%, and we are going to be able to identify those 10% and fix them. We'll be able to identify people that are seemingly well today that are going to be a train wreck 5 years from now. We'll be able to grab them. So we are, as you know, looking forward to getting the data. We reduced the fixed costs for your stop loss by $230,000, implementing a unique strategy. Cost and quality guidance. We presented a strategy of how to direct members to best of class for cost and quality. The agreement is with y'all right now to review. But if you remember from past presentations, it was a funnel that had about, I don't know, you wanted to have a certain procedure done in town. So there are like 65 docs that could do that. But by the time you funneled it down to the best docs, okay, with the best outcomes, there were like 3 or 4 that fell through the funnel. And so this program, as soon as it's reviewed, hopefully it will be implemented soon, and we can start directing people to docs with the highest quality and price. It's a counterintuitive thing, but price doesn't always follow the best in quality. So we're looking forward to getting great quality docs at low prices. Right. The next item on the list is medical bill review. There is a holdup on that. The provider that you and we want to implement is not allowed by Cigna. So, Frank, I believe you've been working on that, maybe with the other attorney at the other company. Okay. Let's see here. Musculoskeletal, Kenneth had mentioned that, MSK accounts for 20 cents of every dollar in general that we in the healthcare world spend is coming from MSK. And Kenneth, it's interesting. The model now is you go to your orthopedic surgeon, and orthopedic surgeon who is going to benefit by cutting on you says, "Yeah, think you need that." Listen, sometimes that's true. You do need it, but many times you will find out that you do not need that. And so the company IMC that we work with will when the person is when the member is at the crossroads and they are recommended to have spinal surgery, for example, we stop the clock right there and have them go see the IMC specialist. And many times they will find out that they don't need surgery whatsoever. It's absolutely amazing.
Kenneth had a story about Leslie that had the experience, and your brother had the experience.
So you just had somebody that ran into that, and that's awesome. So we're already seeing it in action.
What do we know that makes that more accurate than the doctor? I mean, you got a surgeon that does this for a living, says you need it, and you get somebody else who says you don't.
Yeah.
Now I'm sitting in the middle, I'm 50/50.
I don't know if you want to know the answer to that question.
Yeah, but it's interesting.
I mean, is it because we don't want to spend the money?
No, but it's interesting. Look at
Or is it-
Walmart.
That's a great question.
Requested to have the surgery because somebody wants to make the money.
But take a look at what Walmart did with orthopedic also. They mandated that patients have to go to a certain provider, I think it's Mayo Clinic, to get evaluated, and 40% of those patients didn't even need surgery. So, there's that. I mean, surgeons are there for what?
To do surgery.
To do surgery. So our
Not my
IMC
daughter.
method is going to get them at the point of care, because our providers are trained on the assessment and treatment, and then we have the PT provider who's going to do that.
But it's a great question because it's all about communication. You don't want that member to feel like they're being starved from being able to go to the doc, right? Or that you're being cheap or something. And so let them know, hey, after you've gone through this process, it may determine that you do need the surgery. But guess what? You're going to be a whole lot happier if you don't have to have that surgery.
We're meeting next week with an orthopedic group that is looking at adopting that model
Kevin.
for us to be able to use outside the health center.
Here. So not only at the medical
within-
center, but a facility
Yeah,
in the area too.
Right.
But they use the IMC method.
Using the IMC method. If you can get an orthopod to use the IMC method, you're going to get the best of both worlds.
Mm-hmm.
You're going to start with the less pervasive, and then only when it's the only choice, you're going to move to the appropriate level of care. That'll be groundbreaking.
Radiology imaging, we talked about that a little bit earlier. I believe that gets hopefully approved tonight, okay? And so, I believe over the last year, or may have been a couple years of data, I can't remember, but there were, for example, 123 CT scans that were over $5,000. Well, the average cost of a CT scan, nationwide is $1,674. And so we are going to, and we're going to navigate and direct folks to those imaging centers that are just as good as those 5,000 plus ones, but they're at a much lesser rate, and the member is going to be incentivized by just simply not having to pay for that. Versus, if 123 people, got hit with at least $5,000, their deductible got hit.
But just really quickly on that case, some of the patients we saw last week, we wanted them to get either a CT or an ultrasound, and they said, I couldn't do it, I can't afford it. And today we had one that can't afford a sleep study.
Okay.
But there's a lot of training. When you are with your trusted provider, or you're at the doctor's office that may be housed in the hospital, and they say, well, hey, come right on down and get an MRI, you're not going to question that. And so there's going to be a lot of communication that has to take place to tie into that incentive to get people to do things a little bit differently. So not going to happen overnight, but if we, you'll have some good water cooler talk. As soon as you save someone a big deductible, they'll start sharing that news with others.
And that's what we've talked about, using a carrot, the incentive of no copay.
Correct.
No impact on
Yeah.
your deductible to go to these preferred
Yeah,
centers because they are high quality and lower
100%.
cost. But as Dr. Howell and some of the others talked about, as we move forward through our negotiations and consider what plan recommendations we want to make for next October 1, we may want to start shifting away from this total open access to some more steered control that then also allows us to have more consistent savings. Those are just things we're going to have to talk about. That's some of that change that can be somewhat disruptive, but I think it could also be balanced.
Correct.
I had the opportunity to implement a similar program for Lake County schools 2 years ago. First half year, we saved almost $500,000 for the plan. That doesn't count the $150 to $300 per shot that we save the employees. That's a pay raise. So it's an incredible win-win.
On durable medical equipment, DME, not a huge savings, but listen, every penny counts. Examples of DME are like a CPAP machine or whatever for sleep apnea, that sort of thing. So we're currently evaluating this and in discussions to implement that. Opioid management strategies, we've got a doctor in pharma, and they've identified 371 possible opioid issues with only a quarter
Within
year
the school
of
district?
data.
Yes.
Yeah.
Yes.
Yeah.
Yeah.
And so we're working through the consulting agreement, at this time, but.
I thought we shut down all the pill mills.
Nope.
Yeah.
It's still out there.
Wow.
Joint replacement strategies, we're in discussions on that, and again, you can go get a need.
371?
Yeah.
Sorry, I didn't.
No.
That's a big number. I mean, that number is shocking. Out of all the numbers I've seen today, that probably is the most shocking to me.
And what they do,
and I don't mean to stop you, interrupt
it's a really neat concept, is our partner goes through, and there are certain behavior patterns that people on opioids have. And so they go in and drill down in data and look for those patterns. And they don't work with the member. They talk to the doctors, saying, "Doc, do you know that this patient is also seeing this doc and this doc all for pain meds?" And they try to cut the doctors off from prescribing more.
And this is potential, so that number is going to
But
get
also the health
whittled
of
down.
the
No, I understand.
Yeah.
But then, I mean, we hear all these stories, and I don't want to get too long here, but we hear the stories of the suburban house, wife is now going to the bad part of town and buying heroin, right? I mean, I see this 60 Minutes story, and I mean, exaggerate a little bit, but that is the story they've been telling.
Them to treat.
So are these 371 people, if we got a cutting off doctors, are they going to be buying
To
heroin?
get them into treatment.
You get them into treatment.
Correct. So getting the provider involved with that.
What kind? I thought it was a good question.
Well,
It is a good question.
It's a great question. And in many cases, this will roll back to our IMC solution, because a lot of these opioid issues are semi-legitimate.
Yep.
That if we get them into the IMC program and get rid of the pain using non-narcotic options, now you've got a win-win.
Okay. That's crazy. Very interesting.
On joint replacements, we're in current discussions right now, but like for a knee replacement, a lot of folks you go to today charging $35,000, $45,000, $80,000, and we can trim that number down significantly, 18, 20, 22, somewhere in that area. So we are in discussions on that. And the last thing I just want to mention is, the numbers that you saw are potential savings, okay? It all depends on when we roll these things out, how we roll them out. Do we use a carrot? Do we use a stick, et cetera, et cetera, et cetera? There may be some solutions that you go, you know what, let's don't jump in overnight. We need to kind of put our foot in the water a little bit and ease into this over a 3 or 4 year period. And so these are annual savings that we could have if we were all in. It was running perfectly. That number is going to be significantly less, I think, than these numbers.
I was going to say, I just changed from the last number to this is the craziest number that I've seen all day.
Those are our numbers.
Yeah. So again, that is potential. Listen, if we get half of that, I mean, that's huge.
Can you get to $6,000 per member per year? Yeah.
Actually, there's 233 individuals, 50,000 or more. Could somebody pick, like I don't want to select group, but number 50, 100, 150, and 200, 4 people, and look at what they spend and say, on these 4 people, here's 5 things we could do, and instead of spending 50, it would cut, because it seems like once we get there, the answer we're going to get is, we saved you 23 to 31 million, but it went up 56 to 84 million, so you netted 6 million more is where we always get to. So and I don't want you to go, I really want it somewhat random. I don't want you to go find the one who's got something. So if you just pick like 4 at random and say, here's an area that, that would help me really start to understand something specific as opposed to, I mean, I believe that number's there, but I'd feel better if you found 4 things that actually have 30% savings.
And even at Rosen, our numbers will peak and valley sometimes, and it kind of goes like the stock market a little bit. But at any point in time, no matter what, even if we're kind of trending up, our costs are about 40% less than they would have been otherwise. So you might, at some point in time, once we squeeze all the inefficiencies out of it, you're going to see your numbers go up a
Well,
little
at
bit.
least
but
get
you'll
what
be,
the commercial market
yeah.
is.
Yeah.
What the
But we
norm
can't
is.
go from 54 to 70 again. We can't go from 70 to 80.
Right.
To 92.
Right, exactly. So, yeah, it's a slow turning ship, but we are absolutely confident that we're moving in the right direction. Any
I like to do that.
That's good. I apologize again for being late. I got stuck on something that
I did make sure that it is in the records that I was on time today.
Can I ask one question?
Sure.
For everybody in this room on the team, is there anything you need from the board?
Pass the vote tonight.
Just keep passing the votes as we bring them to you.
I'm going to come by and see you too. That's actually why I kind of lost my general doctor, whatever you call it, primary
doctor.
because I didn't go for 3 years. I don't have a lot of conditions, but when we started this clinic, I said, "Hey, I want to make sure that I'm experiencing what the employees are
Drink the
experiencing."
Kool-Aid.
So that's what I did, and so I'll be by to see you.
You go online,
I
call
will
Kenneth.
go online. I will do all the
They
stuff.
take walk-ins.
I think you'll be.
They take. I'm going to walk in.
What, 7 o'clock in the morning?
If y'all don't see me in 20 minutes, I'm filling out the form. 1-star rating.
He's done that already.
So, yeah.
Send him for his colonoscopy.
Thank you all very much.
Thank
though.
you.
Thank you, everybody
I
today.
like
A lot
that. I
of
like
people in the group.
Thank you.
I'll decline. No, hey, actually.